Hello everyone, and welcome to our weekly podcast brought to you by VJOncology. As April marks Head and Neck Cancer Awareness Month, this week's episode will focus on recent developments in head and neck cancer to raise awareness. To begin, Kevin Harrington from the Institute of Cancer Research and the Royal Marsden NHS Foundation Trust in London provides an overview of significant head and neck cancer trial results over the past few months, including Origami 4, Aspinate 4, and Compare.
So I think highlights for me, first of all, the data from Origami 4, in which we've shown that amivantamab, as a subcutaneous formulation given on a 3-weekly schedule in patients with relapsed and or metastatic head and neck cancer, has yielded an overall response rate in the second and third line setting in HPV-unrelated disease that has previously been treated with immune checkpoint blockade and platinum-based chemotherapy, has yielded an overall response rate of 45%, with significant durability of response, impressive progression-free survival data, and we wait to see what the overall survival data will look like. So that looks like a really interesting agent and will be developed further in a forthcoming phase 3 clinical trial in the first line. For me, another highlight has been the findings from a Chinese group that has demonstrated that perioperative camrelizumab, given around the time of surgery and chemoradiation, has been associated with improvement in outcomes in that group in terms of event or progression-free survival events, and we're seeing a good signal there in overall survival. So that, again, is a reinforcement of the data that came from the Keynote 689 study with pembrolizumab. Other than that, regrettably, we've seen a number of really quite negative results coming out of the study. So for the CD47 targeted agent evorpacept, we've seen negative phase 2 randomized studies, both with pembrolizumab and with pembrolizumab plus chemotherapy in ASPEN-3 and ASPEN-4 respectively. We've seen negative data presented by Robert Haddad looking at the activity of an anti-LAG3 and an anti-TIM3 triplet combination. Neither of those agents was adding any benefit to standard of care immune checkpoint based around anti-PD-1 therapy. And again, that's a rather disappointing finding in this study. We've also seen the data from Hisham Mahana for the Compare study, where he was looking at the role of adjuvant durvalumab following completion of definitive chemoradiation for patients with locally advanced head and neck cancer, here in a predominantly HPV-positive population. But regrettably, again, that study failed to meet its primary endpoints. So unfortunately, we've seen a number of studies where we've seen negative data emerging, but we have seen some pointers towards the future, notably in perioperative treatment, and now also with an EGFR targeted bispecific antibody, which is going to progress into a randomized phase 3 in the first line setting. So of course, always some cause for hope.
He also comments on targeting alternative forms of cell death, such as necroptosis, proptosis, and pyroptosis to enhance chemoradiation in head and neck cancer.
So there's been a great deal of interest in new agents that can be added into the curative intent treatment paradigm for patients with head and neck cancers. Regrettably, in the last 5 years, we've seen a number of attempts to add immune checkpoint blockade to standard of care chemoradiation. They have failed. So we have to think freshly as to how to exploit these opportunities to combine new drugs with standard of care chemoradiation to improve outcomes. Now, one of the things that we are learning is that the way in which a cancer cell dies may be relevant to how the body responds to it, and in particular, how the immune system sees that event. So we are now beginning to frame a way of thinking about how to treat the disease, whereby we see the death of the cell not as the end point of what we're trying to achieve, but actually the jumping off point for subsequent treatment that we try to then trigger. So in that regard, rather than simply killing a cell through an apoptotic event, maybe we can reprogram the form of cell death into another type of cell death. So there are a range of different modalities whereby cells can die in a more immunologically visible way. And these include events such as necroptosis, ferroptosis, pyroptosis, and all of these forms of cell death will lead to the release of inflammatory mediators into the extracellular environment and can potentially activate inflammatory responses within the tumor itself. So there are drug discovery programs based around targets such as RIPK1 for necroptosis, which looks particularly attractive, other targets which can potentially modulate ferroptosis and pyroptosis. And I think we will see drug discovery programs coming to the fore in those areas. So it's an area of great excitement.
Next up, Takeshi Kodaira from the Aichi Cancer Center in Nagoya presents results from the phase 3 JCOG 1912 trial, which compared reduced dose versus standard prophylactic radiation.
The current standard treatment for locally advanced head and neck squamous cell carcinoma is high-dose radiation therapy, including about 50 gray of prophylactic nodal irradiation, combined with high-dose cisplatin. While effective, the regimen causes severe late adverse events in over 40% of patients, impacting swallowing, speech, and hearing, and reducing quality of life. To reduce toxicity, we tested a less intensive approach by reducing the prophylactic dose in chemo-IMRT. Eligible patients had P16 negative oropharyngeal cancer, hypopharyngeal cancer, or laryngeal cancer. The experimental arm used a two-step 40 gray method, while the standard arm used SIB 56 gray. The primary endpoint was time to treatment failure, defined as death, progression, treatment discontinuation, or residual disease. We planned for 400 patients, assuming a 3-year TTF1 of 50% in both arms, with a non-inferiority margin of 1.32. Interim analysis in March 2025, patient number 237 patients showed the hazard ratio for TTF1 exceeded the NM margin, leading to early termination. Final analysis included 281 patients, 140 standard, 141 reduced dose, at updated analysis on March in this year. Most had hypopharyngeal cancer and were lymph node positive. No P16 negative, no 16 positive oropharyngeal cancer were included in this study. Results: 2-year TTF1, 71% standard versus 58% reduced dose, with hazard ratio 1.43, also exceeding NIM margin. Slight improvement in hearing loss and hypothyroidism in the reduced dose arm compared to other RCTs on reduced prophylactic dose. Our study had a homogeneous cohort, all stage 3 to 4, P16 negative, and P16 positive patients didn't include it. Locally advanced head and neck cancer with P16 negative disease, indefinite CRT, SIB 56 standard dose CCRT remains standard, and reduced prophylactic dose isn't recommended outside the clinical trial due to the risk of reduced efficacy. As you know, several less invasive treatment strategies has been explored to reduce toxicity. However, no clear advantage in terms of adverse events without compromising efficacy has been reported to data. Our study supports the current standard treatment, which included approximately 50 gray of prophylactic radiation, such as SIB 56 in definitive chemo-IMRT, demonstrating sufficient efficacy. Less invasive treatment approach should be evaluated in well-designed clinical trials with appropriate patient selection based on recurrence risk.
Following on, Andreas Dietz from the University Hospital of Leipzig describes the unmet needs in head and neck squamous cell carcinoma, highlighting challenges in de-escalating treatment for HPV positive and P16 positive patients.
There are a lot of unmet needs in head and neck carcinoma. The one I just mentioned about the HPV positives, the P16 positives. The question is really, what is the best strategy to de-escalate? Because our prognosis is very good, and to find the right program to do that. All studies failed in that direction, so this is still probably not enough understood what to do. But a nightmare are the advanced resectable and unresectable oral cavities, P16 negative oropharynx and larynx hypopharynx. So for larynx hypopharynx, for the advanced, it's very interesting to learn whether checkpoint inhibition adds some benefit for organ preservation. So there are trials running to address that. The next is, what's about metastasis disease? So we see a lot of effort, but if there is relapse, prognosis is getting worse still. And there are a lot of conjugates, ADCs, B-specific antibodies, partners for Bempro, Nivo, and cetuximab, interestingly, which try to combine and to look for better outcome in this group. Results are stimulating, but less enthusiastic discussed, I would say. So we are waiting for the great breakthrough with some good combination of different modes of action.
He also comments on the advancements in reducing late toxicity in head and neck cancer treatment, particularly in regards to swallowing disorders and stiff necks.
In general, the most problem from the past was that swallowing disorders and to get a stiff neck and all these things is impairing quality of life enormously. And on the other side, in at risk, we saw that EMRT and the new strategies for radiotherapy really could diminish these late toxicities following disorders enormously. So we are on a good way to, in a certain way, to decrease late toxicity without paying a bigger price in direction of less survival. So things are moving on, and the combination therapy is fine. And I think the idea to say, keep one modality, and if possible, one modality, that's enough. Don't spread modalities. So at the end, 3-modality treatment is principally bad. I don't think so. You have to combine it. You have to be clever to have reduced the dose of the single modality. Maybe we can one day, if we start up now to gain experience in perioperative immunotherapy, we can start learning how to reduce our borders in resection, so that surgery can be a little bit, let's say, adapted to the outcome of the biology of the disease we learned by neoadjuvant treatments and so on. So there are a lot of things to do, and it's not black and white. It's a very complex thing, and locations are different.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.